have long known that some melanomas are not pigmented and they present as a red lesion and look more like a basal or squamous cell carcinoma. We know that rates of diagnosis, of accurate diagnosis of red melanomas are low, and in a recent study published, the rates of diagnosis of red lesions were lowest of all, and the biggest difficulty in diagnosing any type of melanoma was lack of pigment. And where there was lack of pigment, rates of misdiagnosis rose dramatically. This year there's been a series of publications from ours and other centres showing that red melanomas are not only more difficult to diagnose but are also more aggressive. So red melanomas tend to be thicker, they tend to have a higher mitotic rate, they tend to have a clinically measured more rapid growth rate, and because of all of these things they do metastasise more often and have a higher impact on death rates from melanoma. So they are an important group to target, and awareness of them is too low. Across the board, about a little over 20% of melanomas are perceived by the patient to be non-pigmented or red. If we look very carefully, particularly with dermoscopy, clinicians can actually see smaller amounts of pigmentation in these lesions that may not be evident to the patient, so that can reduce the rate of completely red lesions to 5% or so. So it's very important in a red lesion to look for small amounts of pigment, which could be present in a pigmented basal cell carcinoma, but that will certainly need excision anyway. But if we can't rule out melanoma, and particularly if a lesion is raised and therefore will have tumour thickness and life-threatening potential, if it is predominantly red and we think melanoma is a possibility, it's very important to do an urgent excisional biopsy or arrange for the patient to have an urgent excisional biopsy elsewhere.